Hello, I'm Ken Solt from Massachusetts General Hospital, and on behalf of my fellow speakers, Dr. Z from University of Chicago and Dr. Garcia from Columbia University, I'd like to welcome you to this plenary session applying molecular and systems neuroscience to develop reversal agents for general anesthesia. This session is co-sponsored by the Society for Neuroscience in Anesthesiology and Critical Care. I have two disclosures. Until recently, I had a financial relationship with Takeda Pharmaceuticals as a consultant, and my presentation includes the investigational use of drugs in animal models. So before we get into the individual talks, I'd like to introduce the topic by asking, why develop anesthetic reversal agents? One may argue that modern anesthetics, such as sevoflurane and propofol, have faster pharmacokinetics than older drugs like isoflurane and thiopental, and it may seem that anesthetic reversal agents are unnecessary for this reason. However, I would argue that there are multiple clinical scenarios in which anesthetic reversal would be useful. For example, if one were unable to establish an airway after propofol induction, it would be helpful to have a reversal agent for propofol. Delayed emergence can happen from time to time, and it may even be predicted after a prolonged total intravenous anesthetic. For example, after a complex spine surgery with neuromonitoring, where deep propofol anesthesia is required for many hours, one may expect the patient to take a long time to wake up. There are also situations when rapid emergence and sustained wakefulness are highly desirable, such as after brain surgery, when an immediate postoperative neurological examination is of paramount importance. Also, after bariatric surgery, particularly in patients who have obstructive sleep apnea, somnolence is highly undesirable because it can lead to airway obstruction and hypoxemia. And finally, anesthetic reversal agents may provide a novel therapeutic approach to treat postoperative delirium. Now, drug reversal is commonplace in anesthesiology. In fact, in most cases, we reverse the effects of neuromuscular blockers with neostigmine or shigamidex. But we also have a variety of reversal agents available for other drugs that we commonly use, such as opioids, benzodiazepines, heparin, and warfarin. Which brings us to the question, why don't we have reversal agents for general anesthetics? Well, one reason is that unlike the drugs listed in the previous slide that have very specific molecular mechanisms of action, general anesthetics have complex mechanisms of action that involve multiple molecular targets, as shown in this figure. And therefore, developing reversal agents for these drugs has been a challenge. However, there have been several groups that have been using both molecular level and systems level approaches to reverse the effects of general anesthesia. And we'll be hearing about both of these approaches in the talks today. Which brings me to the topic of my talk, activating dopaminergic neurotransmission to reverse general anesthesia. So there are multiple neurotransmitters that promote wakefulness, and these neurotransmitters are released by arousal-promoting nuclei located in the brainstem, midbrain, hypothalamus, and basal forebrain. Our lab has focused its studies on the ventral tegmental area, or the VTA, which is a key dopaminergic nucleus in the midbrain that is involved primarily in reward and motivation. However, recent studies by my group and others have shown that VTA dopaminergic neurons are not only involved in reward, but are also critically important for arousal. In previous studies, we found that electrical stimulation of the ventral tegmental area reverses propofol and isoflurane anesthesia in rats. So this is a rat under propofol anesthesia administered through a tail vein IV, and he has a microstimulation electrode aimed at the VTA. At this point, the stimulation is off, and as you can see, when the stimulation is turned on, the animal slowly starts to raise its head, starts to breathe faster, and once it flips back onto all fours and starts to ambulate, we consider that return of the righting reflex and return of consciousness. The key point here is that the propofol infusion is still running at the same dose. And we also found in the same study that isoflurane anesthesia was also able to be reversed using this protocol. So we know that propofol and isoflurane, while they do have multiple targets, they're thought to produce unconsciousness primarily by potentiating GABA A receptors. And so recently we became interested in asking the question, does VTA stimulation reverse unconsciousness induced by drugs that target other receptors, such as dexmedetomidine, fentanyl, and ketamine? This is a study that was led by Zheng in my group. This is a rat that just completed a 10-minute high-dose fentanyl infusion and is unconscious. As you can see, when the animal is flipped onto its back, it retains the same position. So this is the classic skeletal muscle rigidity that we see with high-dose fentanyl. Now the VTA stimulation is turned off. At the 25-minute mark, the VTA stimulation will be turned on. And as you can see, immediately the animal wakes up, flips over, and starts to ambulate. And it's clear that the skeletal muscle rigidity has transiently resolved. Now the stimulation is turned off based on our protocol when the animal wakes up. And as you can see, we've sped the video up again. And over the course of the next minute or so, the animal becomes rigid and loses righting again because the stimulation is no longer turned on. So Edlin has an abstract on this. This is still unpublished data, but if you're interested in learning more about this study, please check out her abstract number 1649. So Edlin had 14 animals with confirmed placement of VTA stimulation electrodes. She had 8 females and 6 males. And what she found was that when the animals were rendered unconscious with high-dose fentanyl, as you just saw in the video, they woke up at fairly low levels of electrical stimulation. At 30 microamps, which is the lowest level of stimulation that we used, half of the animals woke up. And by the time she reached 60 microamps, all of the animals had recovered with VTA stimulation. However, she found that in the same animals, ketamine was not reversible at these with electrical stimulation, and only one animal woke up from ketamine-induced loss of righting at a relatively high electrical current of 90 microamps. Now, the data isn't shown here, but there was no difference between the male and female responses to VTA stimulation. And we also found that VTA stimulation was effective for reversing the effects of high-dose dexmedetomidine. So we've also been interested in studying stimulants that activate this pathway. The main dopaminergic stimulant that we've been interested in studying is D-amphetamine, which is a releasing agent for arousal-promoting norepinephrine as well as dopamine. This is a recent study that was led by Olivia Moody in my group. It was published in Frontiers in Pharmacology. And what she found is that when rats were administered high-dose fentanyl, the same dose that you just saw in Edlin's study, and when we gave saline or amphetamine immediately after the fentanyl infusion, there was a more rapid recovery with the animals that received the amphetamine when we looked at time to first head movement, time to 2 paws down, as well as time to full return of righting. Olivia also found that D-amphetamine accelerates recovery from fentanyl-induced respiratory depression in rats. And so, as you can see on the left-hand panel, the baseline pH was around, arterial pH was around 7.35. At the -2-minute time point, which is the end of the fentanyl infusion, so you can see the pH has dropped quite a bit. And the animals that received D-amphetamine, which is the blue line, recovered the pH faster than the animals that received normal saline. We also found that the recovery of PaCO2 was faster with D-amphetamine, and although the results were not statistically significant, there was a trend toward faster recovery of PaO2 as well. So this is another study that was from our group led by Risako Kato, published in Frontiers in Pharmacology last year. What Risako found was that D-amphetamine reverses unconsciousness induced by dexmedetomidine, but not ketamine. So as you can see in in panel A in the top left, after receiving a 10-minute infusion of high-dose dexmedetomidine, the animals received a first and/or a second drug, and time to emergence was recorded. You can see in panel B, when the animals received just dexmedetomidine followed by saline control, the wake-up times range from anywhere from around 60 minutes to about 200 minutes. So it took them a long time to wake up. This is typical for dexmedetomidine, which has pretty slow pharmacokinetics. However, when the animals received 3 milligrams per kilogram of D-amphetamine instead of saline, the animals woke up on average in about 90 seconds. And so the reversal was very rapid. She also looked at a lower dose of D-amphetamine, 1 milligram per kilo, which also woke up the animals very quickly. It took a little bit longer than the 3 milligrams per kilo, but not much. And finally, when she pre-treated the animals with the D1 dopamine receptor antagonist, SCH-23390, prior to administering 1 milligram per kilo of D-amphetamine, the effect of D-amphetamine was essentially abolished, and the wake-up times reverted back to times that are comparable to dexmedetomidine alone. Now, on the right-hand panel are the results for ketamine. Very similar experimental protocol where we gave a 10-minute infusion of ketamine followed by the 2 different drugs. And what Risako found was that when amphetamine was administered after ketamine, there was no difference in the time to wake up, whether we gave 3 milligrams per kilo or 1 milligram per kilo, and the D1 antagonist only extended the wake-up time even longer. Interestingly, when Risako analyzed the data based on sex, what she found was that there was quite a big difference between the wake-up times for males and for females. So as you can see here, this is just the dexmedetomidine data on the left, broken down by sex. The males are blue, the females are in pink. And as you can see, the males woke up in about 75 to 100 minutes, whereas the females sometimes took 2 to 3 hours to wake up. However, both sexes were equally responsive to the arousal promoting effects of amphetamine. So we've also become interested in these sex differences, and Kathleen Vincent in my lab has a abstract at this meeting looking at sex differences based on the estrus cycle. So I encourage you to check out her abstract as well. So to summarize, reversal of anesthetic-induced unconsciousness is achievable with both VTA stimulation as well as with D-amphetamine. What we found in our studies is that VTA stimulation is effective for reversing propofol, halogenated ethers such as isoflurane and sevoflurane, dexmedetomidine, and fentanyl. And our pharmacological studies with D-amphetamine show very similar results, suggesting that D-amphetamine restores consciousness in anesthetized animals, likely by promoting dopamine release from VTA neurons. Importantly, ketamine anesthesia was not reversible with either VTA stimulation or with D-amphetamine. And so in conclusion, it appears that a circuit-level approach may be useful to reverse the effects of several different anesthetics with different receptor mechanisms, but it doesn't work for all anesthetics. And with that, I would just like to thank my lab members, as well as the NIH, James McDonald Foundation, and the Department of Anesthesia, Critical Care, and Pain Medicine at Mass General Hospital for their support. And thank you for your attention.
Today, I'm going to share some of my work about caffeine's effect on the emergency of general anesthesia. I will briefly go through some history. In this slide, you can see we have not had a new anesthetic since 1999. So Kirsten and his colleagues showed that a study on anesthetic pharmacology have declined both for inhalational and for intravenous. And on the other hand, the study on anesthetic management and monitoring have increased. So the anesthetic related mortality declined greater than 10 times for the last 2-3 decades. However, Kirsten and his colleague credit this mainly due to the anesthetic management and the monitoring, not the improvement of anesthetic LD50 and ED50. So what anesthetic is considered good or safe, right? For a patient, he will always say, I want to be out, but wake me up with no pain. For a surgeon, he will say, please make sure the patient will not move and be relaxed. For us, we want to cover everything when we deliver anesthesia to keep the patient safe and comfortable. And recently, we have more concern about the brain health with delirium and neurocognitive function impairment, particularly in the special population, very young and very old. So we need to concern about the brain health with the recovery, and we need to recover well and timely. So why don't we have a new anesthetic since 1999? And sevoflurane and propofol, the commonly used drug, are good, but they're not perfect when you consider the new concern. One of the main obstacles to discover a better anesthetic is the anesthetic mechanism is still largely unknown. So it's difficult to find target-specific anesthetic when there are too many targets for the drug we use. However, that doesn't mean we cannot employ certain strategy to improve the efficiency and safety of anesthetic. Here's the proposed anesthetic mechanism. So currently, our anesthetic work on very diverse targets, from receptor, channel, circuits, transmitter, release. So it's hard to pinpoint a single mechanism when the anesthetic produce an anesthetic state. It is a shotgun approach, like the movie. We got the good, bad, and ugly. So here's a picture of the target of two most commonly used anesthetic right now, sevoflurane and propofol. And you can see that these two drugs have many targets, from GABAergic, cholinergic, all the way to adrenergic, and also they affect almost every other system in the brain. So they're not very specific when the dose reaches the anesthetic level. However, their effect is dose dependent. It's likely to be more specific when the dose is lower. The other thing we will say here is that low active reversal for this drug. And this is one of the main topics we're talking about. How do we actually revert the emergency of anesthesia? So by doing that, we will maximize the benefit and minimize the side effect as well. And this is really the open question. How do we do that? This is an excellent article by Metcalf, Mazur, and Garcia and Cancel. The two people is in this panel today. And they summarize the current knowledge on the mechanism of general anesthesia emergency. And today I will focus on my part on caffeine and cyclo-AMP and adenosine receptor. And you will certainly hear the interesting study from Paul and Ken today. So we mentioned here caffeine is the main topic. It's one of the most commonly used substance in the world. If you use properly, and it's basically they do very little harm if you use the proper dose. All these three drugs, caffeine, theophylline, and phosphorine, have one thing in common. They increase the intracellular cyclo-AMP. And caffeine and theophylline mainly reduce the cyclo-AMP breakdown by inhibiting the phosphodiesterase. By doing that, they break down less cyclo-AMP. So then you will increase the intracellular cyclo-AMP level. On the other hand, phosphorine, by stimulating the adenylate cyclase, by produce more cyclo-AMP. While these three drugs have something in common on cyclo-AMP, but caffeine and theophylline is the two drugs also blocking the adenosine receptor, while phosphorine did not have this function. So before we go to result, we see this is our measurement and a monitor. And we basically use a writing refract as the measurement for consonants for the rat. Here's the first slide. So all the three drugs wake up the rat fast from an isoflurane anesthesia. This rat received 2% isoflurane anesthesia for 1 hour, and they have two sections of anesthesia. One at the end they receive saline, the other one receive drug. And in this case, you can see all three drugs make the emergency time much faster. However, caffeine is the most effective one. The reduction is almost 60% reduction. And more importantly, and caffeine at this concentration does not change vital sign in rat. So to pinpoint a little more on the mechanism, and we use phoscarine, which is mainly on cyclo-AMP, and another drug called plenary is a selected receptor for an adenosine receptor antagonist. So when we use those two drugs independently, they also can produce a fastest emergent time. However, their effect is not as big as caffeine. But when you put the two together, and the effect is almost as fast as caffeine's effect. So we believe this the two drugs, phoscarine and plenary, have an additive effect. So they most likely they don't have an overlap mechanism. We also show here caffeine can facilitate the emergency of a single dose of propofol bolus. And this is saline, this is the propofol, and it's faster. So now we transition to a human trial. So we did a human trial, A healthy volunteer, the two sections, one with saline and one with caffeine, and they both received 1.2% isoflurane with the LMA for an hour. And at the end, we give them saline or caffeine. And you can see all subjects, when they receive saline, they wake up slower than the subject they receive as a session, they receive caffeine. And the subject who received caffeine in that session, and they all wake up at a higher concentration of entitled isoflurane. The brisk monitor score recovered faster as well. The vital sign was not affected, and we basically follow the saline and caffeine over an hour of the vital sign. So this study was published in Anesthesiology in 2018. And one thing I want to mention here is we also did a psychomotor function test. So in the saline section, only 1 hour A subject was able to complete the psychomotor function test 15 minutes after the anesthesia. On the other hand, the subject in the session received caffeine, and 5 hour A subject can complete the psychomotor function test. That tells you they're most likely their cognitive function recovery may be faster. But in this study, we don't have enough power to show the significance for a longer term. So here we also test the caffeine effect in the continuous isoflurane anesthesia in rat. So we give the rat saline or caffeine. It's the same rat in different sessions. So at the beginning of the anesthesia, and then you can see over time we reduce the anesthesia concentration with isoflurane. When they receive saline, and they usually take until 0.4% isoflurane before they emerge. And on the other hand, the animal receive caffeine in the beginning, they are waking up much faster at 0.6% isoflurane. And this is a summary of 8 rat this much faster at 8.8%. So we also show the caffeine can reduce the burst suppression caused by deep anesthesia. And you can see when you apply isoflurane 2% for the animal, and you can see the deep the burst suppression here. But in this session, we give caffeine at 2% isoflurane, and you can see the burst suppression was reduced. Right, as the concentration go down, and you see the burst suppression disappear. And in the saline, they woke up at 0.6%, and in a caffeine section, they wake up at 1% isoflurane. So what is the implication, right? In addition to understand the role of cyclo-AMP adenosine receptor in anesthesia emergency, do we save money for OR time or PACU time? More importantly, can we give anesthesia with less side effect and recover faster to improve the brain health? All these questions remain to be answered in the future. So here I want to change a little bit on the drug here. So Emory Brown had actually published this article a couple of years before. So they suggest we should use a multi-module anesthesia with targeted effect to minimize the side effect and maximize the benefit. So dexmedetomidine is added to the equation to be an adjunct agent to reduce the dose of other anesthetics. with this approach, the target can be more selected with a lower dose of each drug. So dexmedetomidine is a very, very common sedative in anesthesia. It's one of the most selective drugs we use in anesthesia. However, one of the main drawbacks here is the slow recovery. If we leave the infusion of dex to the end, and patients usually have a prolonged emergence and tachycardia recovery. So with this in mind, we want to see whether we can use caffeine to facilitate the recovery of dexmedetomidine. So this picture give us an idea about dexmedetomidine have a fewer target than SIBO and propofol, and you can see that the target is a lot less confusing. And basically, they're acting on the alpha-2 adrenergic receptor. So, but that doesn't mean that in alpha-2 it doesn't affect other systems because they all connected to each other. For example, the largest adrenergic nucleus, the nucleus cerurea, if you have alpha-2 receptor activated, if we do the activity in this nucleus, you will lower the inhibition to the GABAergic system in the preoptic area. So by doing so, you actually potentiate the GABAergic activity. That's how the dexmedetomidine produce sedation and unconsciousness. The good thing here is that if you want to reward unconsciousness, you basically can reward the alpha receptor activity here, and you antagonize the alpha-2 effect. So is dexmedetomidine reversible? The answer is yes. In animal, competitive alpha-2 antagonist atipamezole was used commonly. Although it's not very effective, but in a 10-to-1 ratio, and you can revert the animal pretty efficiently. But however, in human, and you need the 40 to 100 to 1, means there's a lot more atipamezole to revert the death. So this is the problem. When you use such a high dose atipamezole, you can reverse the human the sedation effect. However, it produces side effects like hypertension, emesis, and other neurological side effects. Right, so that's not ideal. That's what we didn't have it clinically. Recently, Cancel and his group showed that the amphetamine is very effective to revert the death in rat. But today, clinically, time is the only solution for our patient. What is the molecular mechanism of dexmedetomidine? So it's much simpler than SIBO and propofol. So you activate the alpha-2 receptor, and basically you're going to activate the G protein, inhibition G protein signaling pathway. By doing so, you're going to deactivate the adenylate cyclase, and then subsequently you reduce the production of cyclic MP. Right. So by reducing the cyclic MP, what it does here, you can see is to reduce the transmitter release. So activation of alpha-2 receptor is going to be lead to decreased cyclic MP and reduce transmitter release. This is the simple pathway. So we mentioned earlier, caffeine can produce higher intracellular cyclic MP. So the question we asked here, will caffeine counter the dexmedetomidine effect here? So we have two strategies to do this, right? One is we think if the caffeine is powerful enough to do it on their own, right? But we didn't see that in propofol and isoflurane. And the other alternative, we use a basic pharmacology hypothesis. For example, when you give antagonist to an agonist, you basically shift the dose response to the right. Functionally, and you can see the animal could be, if you sedated by dexmedetomidine, you can change from a deep sedation to a lighter sedation. By doing that, so we will help the caffeine to revert the dexmedetomidine effect, right? So here's our result. So we give 10 mic per kilo of bolus IV to the animal, and we measure the whitening effect. So usually when you give saline at the end of the after the dexmedetomidine, it takes about 35 to 45 minutes to recover the whitening effect. And on the other hand, when you give 5 mic per kilo atipamezole, which is 0.5 to 1 ratio, and the effect is about 10 to 15 minutes. So it's an effective but not fast. However, when we add caffeine into the equation, and you can see they recover within 1 or 2 minutes. So we do the similar experiment, but in this case, we give caffeine alone, 25 milligrams per kilo, and you can see they do have some effect, but again, they're not very efficient. But when we add atipamezole, 5 mic per kilo together, and they are same thing, 1 or 2 minutes, they wake up. So in this figure, we show that we give the epipramazole is a little higher, from 0.5 to 1 to 1 to 1. In this case, again, the epipramazole, even 1 to 1 ratio doesn't give a fastest, like a instant recovery. However, when you give caffeine on top of it, it's almost, the animal wake up almost instantly. Most of them within a second. So this is the comparison between 5 ml to 10 ml with caffeine. And clearly, when you give 1 to 1 versus 0.5 to 1 ratio, is faster. However, you take the caffeine out of the equation, and the 5 ml to 10 ml have no difference. So caffeine does make a difference here. So finally, I want to show you a spectrogram with or without reversal in the same breath. So this is giving an infusion for 35 minutes of dexmedetomidine. At the end, here we let the animal wake up on its own. It takes about 35 minutes. In this case, we also ended at the same time with infusion. We give epipramazole, and you can see this is 1 to 1 ratio. It doesn't seem to change anything. But the moment I give caffeine, and the animal instantly wake up. So here's the summary. So we show here caffeine can facilitate emergency anesthesia. So the effect is likely mediated by the increase of cycloAMP and antagonism of adenosine receptor. When the anesthetic at a lower concentration, caffeine can be more effective. So at low dose of with the low dose of epipramazole, caffeine can revert the sedation effect with dexmedetomidine very quickly, and this approach may avoid the side effect of high dose epipramazole. So we need to examine the effectiveness and safety of caffeine and epipramazole on multimodal approach anesthesia with dexmedetomidine. So we think that caffeine and epipramazole have a potential to be an excellent reversal for the multimodal anesthesia with dex. So this is the people who are doing the study with me, and I also thank the people supporting us. Thank you for listening, and I'm happy to answer some questions.
Hello, I'm Paul Garcia. I'm delighted to speak at the plenary session sponsored by the Society for Neuroscience and Anesthesiology and Critical Care. The title of my talk is Inducing Emergence from General Anesthesia with Flumazenil and Epipamazole. This slide contains my conflicts of interest. None are relevant to this talk. I am a named inventor on several patents to which Columbia University is the owner. Thus far, no contracts, no licenses, no royalties, no stock, no financial relationship exists. These are the objectives for today's talk. I will explain how activation of neurophysiologic circuits in the cortex is related to arousal from sleep and anesthesia. I will describe the difference between emergence and recovery from anesthesia, and I will review preclinical literature regarding pharmacologic and non-pharmacologic manipulation of cortical circuits to influence post-anesthesia behavior. When I was training as an MD-PhD student, I worked in a sleep pharmacology lab that was investigating GABA antagonists to wake patients diagnosed with hypersomnic disorders. This inspired a good deal of my more recent work on how patients regain consciousness after general anesthesia. Here, I present some of the data from a publication in Science Translational Medicine. We see that with practice, hypersomnics still exhibit more than 10 lapses of attention during a 3-minute vigilance task. For comparison, those of us without hypersomnia would typically exhibit less than 2 lapses. Administration of flumazenil in the center and right panel improved task performance in these patients, and this effect was sustained for hours. In many cases, flumazenil and another drug we examined, clarithromycin, helped these patients live much more normal lives. Here I show the publications on clarithromycin. And here is some of the data from the Journal of Neurophysiology publication. We first demonstrated that injecting depolarizing current into a cortical neuron exposed to clarithromycin increases the frequency of firing in this neuron. We thought that this was a GABA-mediated effect because increasing clarithromycin will result in greater inhibition of GABAergic minisynaptic currents. In this paper, we also demonstrated the possibility of an increased seizure risk with clarithromycin. You may be surprised to learn that flumazenil not only maintains vigilance in sleepy people, but also is an anticonvulsant. Flumazenil is an imatazobenzodiazepine derivative and shares chemical similarity with classic benzodiazepines like diazepam. So it acts as a competitive antagonist at the benzodiazepine site on the GABA type A receptor. Interestingly, it also exhibits weak partial agonism at this same receptor. This topic was more completely explored in one of the first projects I started working on in my own independent research laboratory. These graphs demonstrate that in rats given flumazenil, waking behaviors were hastened after isoflurane anesthesia. The top trace and its corresponding inset to the right are from a rat that received a saline injection near the end of an isoflurane anesthetic. The bottom trace is from an animal that received flumazenil. The timescale is the same for A and C as well as B and D. The reestablishment of an awake EEG is marked by this arrow, revealing a hastening of both cortical activation and ambulation attempts by flumazenil. I want to make a quick remark that because of our tethered EEG setup, we could not place these animals on their back. Of course, most of the audience may be familiar with the exceptional work of my colleague Dr. Ken Solt and others in this area who elegantly describe some of the brainstem arousal circuitry involved in the return of the writing reflex. Since the time of this original publication, we have modified our recording setup and can now record from animals while they are supine and on their back. On the previous slide, it may have been hard to appreciate the subtle spectral changes that occurred prior to EEG wake in these experiments. These spectrograms demonstrate that in the electrodes over the frontal cortex, flumazenil administration is associated with increased neuronal activity in the beta range. This activity is representative of cortico-cortical communication and might represent a top-down influence on anesthetic emergence. The statistical quantification is better seen in these power spectral density plots. Of course, observing neurophysiologic activity representative of cortical activation might signify that the cortical circuitry is powered up, but it really doesn't mean that the circuits are processing information at peak performance. At what point do we consider the anesthetic over? When the animal's cortex begins to interpret information, or maybe when it has returned to its baseline cognitive status. The most recognizable feature of clinical anesthesia is the abolishment of consciousness. Of course, what makes anesthesia clinically relevant is its reversibility. Unfortunately, most clinicians don't do a great job using consistent nomenclature regarding the end of our anesthetic, and we often confuse emergence with recovery. I hope to help distinguish these from each other. I like to divide research in this area into two main questions. One focused on emergence and the other on recovery. Although it is a bit of an oversimplification to only have two research questions, certainly the experiments we describe in this forum have implications for both. Nevertheless, it is helpful to make this distinction because when we transition from the preclinical laboratory to the clinical environment, definitions, topics, mechanisms can easily get confounded. This is especially important to the clinical anesthesiologist as they might wish to recognize abnormal neurocognitive trajectories and decide on a plan to either prevent or diagnose any adverse outcome. Adverse outcomes such as delirium or perhaps a persistent perioperative neurocognitive disorder. The main question for emergence might be, what are the neuronal mechanisms involved in regaining consciousness or conscious awareness? Whereas the main question for recovery might be, what neuronal network physiology must be restored for a brain to return to its cognitive baseline? Using sort of cartoonish language, I often describe emergence and recovery thusly. In the operating room, we might hear, as the dressing is going on the wound, that the patient is about to, quote, wake up. Yet in the recovery room, we might also hear that, oh, that person can't go to the floor yet as they are still waking up. This vague terminology we use impedes our clinical and scientific progress in the area. Clearly, after patients emerge from general anesthesia, typically in the operating room, they might know their name and they might be able to follow some simple commands, but they may not be able to describe the sequence of doctor's appointments that led to their diagnosis. Sometimes they are aware of a drain or a Foley or a bandage, but they're not quite sure why they have it. Vague terminology can make it difficult to properly categorize a patient as either normal or abnormal after anesthesia. In the left panel, we can imagine two colleagues wondering why the patient is breathing, but not opening their eyes after a 4-hour spine case. In the right panel, this patient is clearly no longer unconscious, but has an impaired consciousness. Consciousness in this individual might be present, but not normal. What is the difference between these two patients? Well, one, I would say, has failed to emerge from anesthesia, while the other has emerged and has a recovery problem. In my opinion, the simplest clinical definition for end emergence and the start of recovery is if the patient is responsive to shake and shout, as this distinguishes from natural sleep. We must stimulate our patient to determine if they are sleeping versus being anesthetized. Patients who have yet to respond to shake and shout should be considered still unconscious, as they have not yet achieved end emergence. On the other hand, those that maintain eye contact but answer questions slowly or perhaps even inappropriately may not be at their cognitive baseline, but certainly cannot be considered unconscious. The gold standard to experimentally determine emergence from unconsciousness has been the return of writing reflex in a rodent preparation. Mice and rats are prey species. They don't sleep on their back, so if they're quiescent, we put them on their back to distinguish anesthesia from sleep. The sensation of being on their back is a mild, constant, non-aversive stimulus. In order to understand abnormal cognitive recoveries after anesthesia, we need a more sophisticated preclinical model. So how do we study this in an animal? In contrast to Ken's very sophisticated behavioral tasks that grade and quantify the whole spectrum of recovery after anesthesia, I believe there is still much to be gained by using a simple binary behavioral approach. I feel that this simple test does quite a good job in evaluating when the animal has achieved a very specific milestone in the recovery process. We call this test the sticky dot test, and it is modified from preclinical stroke models. This is a drawing of a rodent forepaw. As the animal is unconscious, a piece of adhesive tape is affixed to the paw. If this is done in an awake animal, they typically only need between 5 to 15 seconds to shake their paw and attempt to remove it. But after anesthesia, you would be surprised. Most animals don't shake their paw and make an attempt at removal of this sticky piece of tape until after 20 minutes or sometimes longer. In 2018, we published this study, which compared anesthesia reversal by yohimbine and atipamezole in a GABA-free anesthetic, specifically a mixture of ketamine and xylazine. For those not familiar with xylazine, it is an alpha-2 agonist, much like dexmedetomidine. Xylazine is mostly used in veterinary medicine and not in humans out of concerns that it is a mild carcinogen. There are two alpha-2 antagonists with high affinity for the alpha-2 receptor. Yohimbine is an indole alkaloid derived from the bark of the yohimbe tree, an evergreen in West Africa. It has highest affinity for the alpha-2 receptor, but also antagonizes the alpha-1 receptor. It is about 40 times more selective for alpha-2. Atipamezole is also an alpha-2 antagonist with a much higher alpha-2 alpha-1 selectivity, specifically 8,500 to 1. 15 minutes after inducing anesthesia with a mixture of ketamine and xylazine, IP injections of saline or reversal agent were performed and behaviors were measured. Mice given yohimbine and atipamezole nearly immediately began to flick their whiskers or move their forelimbs. However, those given yohimbine stalled a bit with their return of righting reflex and emerged from anesthesia not as fast as those given atipamezole, but faster than saline-treated animals. Recovery was a bit of a different story. The animals that received yohimbine were not significantly faster to shake the sticky dot when compared to control animals. We attributed the difference between yohimbine and atipamezole to antagonism of cortical alpha-1 receptors, and recapitulation of these results with an alpha-1 specific antagonist, prazosin, supported this reasoning. Like the experiments with flumazenil, a cortical influence on emergence and recovery is apparent. Notably, this cortical effect may be more important for recovery than for emergence. The last project I want to highlight was featured by the IARS Twitter feed last year. In this study, we examined the effects of prehabilitating the cortical tissue in young adult animals with transcranial stimulation before an isoflurane challenge. Our animals were subjected to a surgery to implant electrodes and were delivered DC stimulation 20 minutes daily for 10 days before an anesthesia challenge and examination of their post-anesthesia behaviors. The stimulation did not affect sleep or activity in these young adult animals. However, transcranial DC stimulation performed before the anesthesia challenge did affect emergence and recovery in these animals. In conclusion, flumazenil has successfully been used to treat patients with hypersomnic sleep disorders. Flumazenil has a mild effect on hastening recovery from isoflurane anesthesia. Activation of cortical networks prior to righting was noted with flumazenil treatment. Alpha-2 agonists also can hasten emergence from ketamine xylazine anesthesia. Cortical networks were also seen to have an influence on emergence and slow recovery, especially when disruption of alpha-1 signaling occurred. And finally, transcranial DC stimulation applied to the frontal cortex can hasten emergence and recovery. Thank you for your time. I have all of these great people to thank for collaboration and working in my research group. Thank you for your time.
Great. Well, thank you so much for participating in this session. We've had quite a lively chat already on the website. There were some questions that the speakers have already answered, but there's one that came up from Boris Heifetz I just wanted to bring up first. The question was about using lamotrigine as a reversible agent for ketamine. I personally am not aware of any study looking at that, but I think it would be quite interesting. I don't know if the other panelists, Dr. Z or Dr. Garcia, have anything to add about that.
Will say that I would be very surprised if it works because ketamine is a very dirty drug. We like to talk about its NMDA antagonism, but I'm not convinced that it has very much at all to do with how it makes anesthesia or surgery possible. I'm not even sure if we should really call the effects of ketamine unconsciousness. It kind of depends on how you define and don't define consciousness and unconsciousness, because it's very, very different than the other drugs we use.
Yeah, I still haven't have a handle of how to use ketamine, particularly when you use it with desmetanide. I know they use a lot in the animal by doing IP, but we are talking about you want to use in a very safe window, which is hard to titrate because ketamine have multiple effects. It's not like this. You're talking about nanomolar versus millimolar. That's a very different drug.
So Dr. Paransky was quite active in the chat, asked several questions. One was about the use of TCI and if the TCI, target-controlled infusions that are available in other countries may be beneficial to minimize delayed emergence. I would think that is certainly true. Unfortunately, in the US, we don't have TCI available, but I was hoping that perhaps some of our international colleagues may be able to comment on that question. Or Dr. Paransky himself, because he mentioned that he had actually played with this a little bit.
Well, thanks, Ken, can you hear me?
Yes.
Okay, thanks, Ken, for handing me, although I'm not a specialist. I've tried it because for the same reason that you mentioned, you're not supposed to use it here. In order to really implement it, what you need is the connection between the computer and a computer-controlled pump. And we did not have that because we didn't have the money to purchase a pump. Now, what we've done, it's very simple. We downloaded stand pump application on a laptop and followed its instructions, which is dirty, but this is what we could do. And we didn't do big times neurosurgery because this is where it would really provide, or some kind of really long cases where it would really provide a advantage. But we were impressed by the fact that targeting a specific target concentration, effect site concentration, we were waking those patients up very quickly. Now, from propofol, this was propofol anesthesia, not volatile anesthetic. So I don't know. There should be kind of like Europeans who are using it routinely, because in Europe there are no regulatory problems between connecting the pump to a computer and using it in the OR, as far as I know.
Any comments from our European colleagues or anybody else about this topic? Well, I think one of the issues that Dr. Peryansky brought up, which is an important one, is what I sort of addressed at the very beginning when I introduced the topic, which is, do we really even need anesthetic reversal agents? I think I had a feeling that in and of itself would be somewhat controversial. I feel that in most cases, to be frank, we probably don't need anesthetic reversal agents because the kinetics of the drugs we have are pretty fast. But I did describe some scenarios where it may be useful. And I think it's also important, there was a little bit of a chat back and forth between Dr. Garcia and Dr. Peryansky about using these tools to better understand arousal states and how we're affecting consciousness. And I think one of the other important issues to bring up is that many of the talks at this meeting have shown that there are long-lasting effects of anesthetics that we still don't quite understand. A lot of these things like postoperative delirium, cognitive problems, and things like that are clearly do not track the pharmacokinetics of these drugs being washed out of the body. They're long-lasting effects. So I think there's a lot more that we can learn about the brain using some of these tools. And so just wanted to put that out there. Any other comments about that or questions from the audience?
Ken, yes. I want to answer George's question. He did a study with 200 milligrams of caffeine, which didn't seem to show up any different in recovery time. In our study, we used 7.5 milligrams per kilo, which is, if you're a 70 kilo patient, it will be like 500. So that's clearly dose dependent. So if you drink a little coffee 2 hours before, it's very unlikely with the half-life of 5-6 hours. It probably will have very minimal effect if you do that a few hours ago. And so you have to do it at the right time, at the right timing, and with the doses enough to overcome the other anesthetic effect. Particularly with propofol, we actually monitor for an hour to take the sample, blood sample, and measure the propofol level in the blood. There's quite high concentration with propofol, even after an hour, even the patient already awake. So they can last forever. So one dose of caffeine may not be enough for that if they last longer.
Dr. Epstein brought up a question about a study in Japan where apparently most patients go straight from the OR to the floor. Again, sort of asking the question of do we need reversal agents if we can get people out of the OR to the floor fairly quickly. Is Dr. Epstein on the chat right now? I was hoping that perhaps he could comment about this study. Quick glance, I don't see him here, unfortunately. Yes.
Yes, if I can make a comment, I'm trying to find the raise your hand button, but I can't find it on my screen. So It chimes maybe in some way to what Dr. Epstein said. You have the option, if I've been in the business for long enough, the fact that anesthetics may have long-term effects after complete elimination from the body is something which came up relatively recently. The fact that anesthetics may exert a lot of those effects, not by the receptors or by the mechanisms that we thought they did, has developed over the last 20 years, thanks to your work, thanks to the work of all of us who have been in the mechanism of anesthesia world, right? And so every new drug that you bring in, you have to consider that it may have A, immediate collateral effects, B, long-term effects. And there was one little point that in Dr. Z's talk that I wanted to mention. When you showed the emergence of rats, I think from the ketamine, you had this one single outlier. All the rats had kind of like the same response and the time, and there was one outlier which was way out there. And I think that these are the outliers that point towards fundamental genetic background effects that we lose by averaging those slides. So this rat, I would like to know what his kind of genome tells us about why he responded differently to the drugs that you administered. Sorry for the interruption.
We asked the question too. So, but despite this, the one rat is instead of 30 seconds, it's going to be like 100 seconds. So it's still like a 95% reduction, right? So they do have a significant effect, but this rat is clearly different. We did it twice. They have the same effect. So I wish I can figure out why this outliner, what kind of metabolism they have and things like that. So it's very interesting when you give desmometamidine infusion. So it's pretty variable. I think Ken can tell you if you give it a higher dose, if they can sleep for 3 to 5 hours with those animals. Like you can predict some is 3 hours, some is 5 hours. So that's why it is hard to, unless you draw the blood and see whether their plasma level of death is higher in that particular rat. That's the only thing you may find out.
Well, my general kind of direction of thought right now is, of course, biased, but pharmacokinetics is the next frontier in anesthesia. We don't respond all to the same way to even such non-specific drugs as general anesthetics. So, and your rat may be one of those guys.
Dr. Palanca has a question in the chat. He asks if how does pre-anesthesia sleep structure impact the variance in anesthetic emergence experiments? Does sleep deprivation, does deprivation of certain sleep stages before the anesthetic and emergence lead to different phenotypes? I personally have not done those kind of studies. We try to do the studies at the same time of day. I would mention that these animals are on a normal sort of day-night cycle, so they should actually be sleepy. Being nocturnal animals, they should be sleepy during the day when we're doing these experiments. So if anything, if sleep affects this, then they should be sleepier and harder to wake up, I would think, during the day. But I'm curious to see what Dr. Garcia and Z have to say about that.
Sure, Ben, that's a really good question. Avery Tung from Chicago did some work on, I believe, with propofol and sleep deprived them, and then kind of looked at their sleep rebound. George, he's on the call. He can probably comment on some of his work too, which has gone into this. Very briefly, some work that I haven't published shows a very mild effect kind of during the day. If you did these experiments, exactly like what Ken said, if you did these experiments as 8 o'clock in the morning versus doing them at 6 o'clock at night, you know, I would not compare those results in my lab. Basically, all the things that we do are pretty much between 10 and 2. And that's when we get the most kind of like consistent results. If you get close to the ends, otherwise you're talking about doing a reverse light cycle, which is kind of difficult. I'll also just mention that a lot of our animal facilities, I was on the IACUC for a long time at my previous institution. You know, if you're thinking about getting into this, you should try to convince your IACUC to really have a 10 and 14 cycle instead of a 12 and 12 cycle, because that's really on the cusp. It's the 12 and 12 about when so you get a lot of, I think our results would be more consistent if we had a 10 and 14 cycle to either clearly put them in kind of the winter or the summer, as opposed to when they're in that spring or fall kind of 12 or 12 for these animals, because I think that there are some animals that they're always on this unstable equilibrium for some of their hormones, some of their circadian rhythms, et cetera. I think that, you know, there's so much variability in humans that I accept that variability and just do more animals, if you will, for the rodent kind of work. But you know, there's also night owls and early birds in humans. So, you know, if we want to apply this to the clinical condition, I accept that amount of variability in what I'm doing, because these animals are genetically all like brothers and sisters. They're basically from the same family. So it's something that we ought to consider with our experiments.
I think that's great, and I just want to reinforce the variability might be a very interesting finding, and not necessarily something to be not liking, but just it might be very, very interesting understanding underlying mechanisms. So,
yeah, clearly the work that I did with the hypersomnics was like, why do these people sleep all the time? And it's a little bit of a rare condition. So I completely agree.
Dr. Bertaccini brought up a great question. He said, has there been any application of either transcranial stimulation or drug reversal agents to coma patients, or the other most prominent sedative, namely alcohol intoxication? I'm aware of some limited literature in the coma space. Nico Schiff published a very well-known paper in Nature about 15 years ago, I believe, showing that thalamic stimulation helped wake up a patient who was in a minimally conscious state for years. And I'm actually collaborating with a neurologist at Mass General to look at IV methylphenidate, which is similar to amphetamine, as a wake-up agent for coma patients that he treats in the ICU. So there are studies underway to look at this question. About alcohol per se, I actually don't specifically know. I don't know if the other speakers have any comments about either of these.
Haven't seen anything about alcohol. There's some work from University of South Carolina about transcranial DC stimulation and analgesia. It's also been applied to patients with Alzheimer's disease and word finding. I think that this cortical stimulation, some of the work, you know, George is on here. He and I have spoken a lot about the top-down controls here for that they're important, just as important as the bottom-up kind of controls for this. I think that it goes in both ways, for emergence and for recovery. And I think that the kind of non-specific brain stimulation that you get with these non-invasive techniques like transcranial DC stimulation, of which we did an animal model for and have some experiments with human beings as well. I think it's going to be something we will look at in the future as all clinicians.
So I don't know about alcohol. Alcohol is probably long lasting. It's very hard to reverse them instantly. But there's a case report in Japan. They use desmotomidine to reverse caffeine overdose, which is quite interesting. But it's just a case report, not the real study.
Well, unfortunately, I believe we're actually 5 minutes past the scheduled end of our session. I really want to thank my fellow speakers and for everybody who joined us for this very stimulating discussion. I really appreciate everyone's time, and I hope you enjoy the rest of the meeting. Thank you very much.
Thank you.
Thanks, Ken. See you guys. Bye, everyone.
All right, thank you.